Good day, fourth year students. Today we have the seventh hematology lecture. It will be about myeloproliferative disorders or neoplasms. I hope you will enjoy the lecture. The objectives: by the end of this lecture, the student should be able to 1. Classify myeloproliferative disorders and identify their triggering event. 2. List the clinical features of myeloproliferative disorders. 3. Describe the clinical progression of the myeloproliferative disorders. And 4. Discuss briefly the diagnosis and treatment of polycythemia rubra vera, myelofibrosis, and essential thrombocythemia. We start with a question. What is the cell origin of myeloproliferative disorders? A. Stem cell. B. Megakaryocyte. C. Fibroblast. And D. Myelocyte. You have only one choice, and I will not give you the answer. You will find the answer during the lecture. The myeloproliferative disorders are neoplastic or clonal disorders of hematopoietic stem cells. There will be overproduction of one or more cell lines, with usually one of the lines predominating. In these disorders, there is myelofibrosis, which is a secondary event. And also these disorders are liable for the transformation to acute myeloid leukemia after many years. The classification of myeloproliferative disorders includes 1. Polycythemia vera, 2. Myelofibrosis with myeloid metaplasia, and 3. Essential primary thrombocythemia. In this diagram, we can see that the bone marrow stem cells will give rise to granulocyte precursors, red cell precursors, and megakaryocytes. The megakaryocytes proliferation induces reactive fibrosis. Previously, we included chronic myeloid leukemia in the classifications of MPN. Recently, chronic myeloid leukemia has been separated. Chronic myeloid leukemia has the propensity for transformation into acute myeloid leukemia in 70% of cases. Polycythemia vera and essential thrombocythemia, they have lower propensity for transformation into AML, 10% of cases, while myelofibrosis, around 1/3 of cases, will transform into acute myeloid leukemia. And also in polycythemia vera, later during the course of the disease will end with myelofibrosis. Now we come to discuss polycythemia. Polycythemia is classified into a true or absolute polycythemia, in which there is true increase in the number of red blood cells, and it is mainly divided into primary polycythemia, and which is the bone marrow disease, and the secondary polycythemia, which is reactive. It could be erythropoietin dependent, either induced by hypoxia, or it is not related to hypoxia, and erythropoietin independent. The other group is the apparent or relative polycythemia, in which there is a decrease in the plasma volume, and the most obvious cause is dehydration, and this condition will disappear after correction of dehydration. This is the list of the causes of secondary polycythemia. We start with the erythropoietin mediated, and it is either driven by hypoxia. The most common cause is chronic lung disease. Other causes are there, you can see it. And it could be not related to hypoxia. There is pathological erythropoietin production, mainly either from malignant tumors like hepatoma and renal cell carcinoma, or could be from non-malignant conditions like uterine leiomyoma and renal cysts. Now we come to a case scenario. A 55-year-old lady came with headache and dizziness of 3 months duration. She is hypertensive, diabetic, and smoked heavily for the last 25 years. Her PCV is 50%. Finding one of the following is consistent with the primary polycythemia in this patient. A, oxygen saturation of 90%, B, normal splenic size, C, high serum erythropoietin, and D, mutated JAK2 test. And I will not give you the answer. You will find the answer during the lecture. Polycythemia vera is a chronic clonal myeloproliferative disorder. It is characterized by an absolute increase in the number of red blood cells. The incidence is around 2 to 3 per 100,000 population. The median age in the Western countries is 55 to 60 years, but in our country, in Iraq, many patients are young. They are in their 30s and even the 20s. Females predominate, and the hallmark of this condition is the molecular abnormality JAK2 mutation, which is a key factor in the development of this disease. In this diagram, we can understand the role of JAK2 mutation in the pathogenesis of polycythemia vera. On the left, the normal person has receptors for erythropoietin on erythroid progenitors. The receptor activation by erythropoietin will lead to activation of the JAK2 signaling pathway, and this will lead to activation of genes of growth and proliferation. There is a negative feedback that will shut down this activity depending on the need of the body. And polycythemia vera, the JAK2 mutation will lead to continuous activation of the JAK2 signaling pathway with dysregulated gene activation. The negative feedback is lost, and this will lead to the overproduction of the erythroid and later on other cell lines in the bone marrow. The clinical features of polycythemia rubra vera, the beginning of the disease is usually asymptomatic in many patients. Sometimes it is discovered accidentally during investigations. The most common features include headaches, red face in some patients, pruritus after hot bath, and later on the patient will start to manifest vascular occlusion attacks like venous thrombosis and arterial occlusion like transient ischemic attack, stroke, and myocardial ischemia. And also these patients may manifest a skin problem, which is called erythromelalgia, in which there is erythema and dysesthesia in the fingers and toes. The patient may develop splenomegaly, and later on during the course of development of the disease, the spleen may reach a huge size, And also these patients, they are liable for gouty attacks due to hyperuricemia, and they have increased incidence of peptic ulcer disease. The lab investigations will show erythrocytosis. Usually the hemoglobin is more than 17 grams per deciliter. We may find granulocytosis, basophilia, and eosinophilia in some of the patients, and also we may find increase in the platelet count. The bone marrow study will show a hypercellular marrow and increase in the fibrous tissue and the number of megakaryocytes. There is also hyperuricemia, and some patients will have increased serum vitamin B12. The ultrasound of the abdomen usually reveals splenomegaly, but not in all patients. And this is important. The serum erythropoietin is decreased, and the hallmark of the disease is the presence of positive JAK2 mutation by PCR study in more than 90% of the patients. The diagnostic criteria for polycythemia have been introduced so that they will aid in differentiating polycythemia vera from other causes of polycythemia. We have this diagnostic criteria system. We have the major criteria, which are two: hemoglobin more than 18.5 gram per deciliter in men and more than 16.5 gram per deciliter in women. The second major criteria is the presence of JAK2 mutation. The minor criteria include: one, bone marrow biopsy showing hypercellularity for age, with panmyelosis, proliferation of the all lines of bone marrow, with a prominent erythroid, granulocytic, and megakaryocytic proliferation. The second criteria is serum erythropoietin level below the reference range for normal. And the third one, it is rather a difficult test. It is not routinely done, in which there is growth of the erythroid colony-forming cells when they are cultured in tissue without the need of erythropoietin. The diagnosis of polycythemia vera requires both major criteria and one minor criteria, or the first major criteria and two of the minor criteria. In this photo of a blood film, we see the presence of a nucleated RBC in the upper part. Lower down, we see two basophils with coarse granules and one myelocyte, and the presence of these cells may indicate progression of fibrosis in a case of polycythemia. And this is a bone marrow biopsy of a patient with polycythemia vera. You see that the bone marrow is hypercellular, and also we can see the presence of many megakaryocytes. They are increased in number in these sections. We continue the case scenario of the patient. The patient had a positive JAK2 mutation test, and so now the treatment of this lady includes all of the following medications except A, aspirin, B, allopurinol, C, phlebotomy, D, hydroxyurea, and E, splenectomy. And the answer, you will find it during the lecture. The treatment of polycythemia vera depends mainly on reduction in the level of hemoglobin or the PCV in males less than 45% the level of PCV, and in females the PCV should be less than 42. And this is important because if these levels are continuously increased, they will lead to the development of thrombotic attacks. In patients who are at high risk of thrombosis, patients over 70 years of age who have a prior thrombotic episode, or when the platelet count is more than 1 million, or in the presence of cardiovascular risk factors, we need to suppress the bone marrow activity by the administration of hydroxyurea, an oral cytotoxic agent. Also, these patients should receive aspirin to decrease the thrombotic episodes. Alpha interferon is used mainly to decrease refractory pruritus, and also it is suitable for the treatment of a pregnancy with polycythemia vera. The other drug named anagrelide is used mainly to manage thrombocytosis that is resistant to other treatments. It does not change the size of the spleen. Allopurinol is important because it decreases hyperuricemia. And recently, new drugs, JAK2 inhibitors, have been introduced to treat refractory cases. They help to decrease the splenic size in resistant cases. And what is available now in the market is the drug named ruxolitinib. It is used in refractory cases. The prognosis in treated patients is usually good, but many patients after more than 10 years will start to change into myelofibrosis, and around 10% of the patients will go into acute myeloid leukemia. The causes of death in patients with polycythemia include thrombotic episodes, major bleeding episodes, and the transformation into acute myeloid leukemia. We continue the same case scenario. The above mentioned lady developed 10 years later exertional dyspnea, and her hemoglobin became 80 grams per deciliter. You can select more than one possible explanation. The choices include A, iron deficiency, B, GIT blood loss, C, transformation into acute myeloid leukemia, D, developing myelofibrosis, and E, the side effect of hydroxyurea. You can choose more than one possibility, and you will find the answer in the lecture. Now we come to the other topic, primary myelofibrosis. Primary myelofibrosis is a clonal hematopoietic stem cell disorder that usually ends in bone marrow failure. There is also myeloid metaplasia or extramedullary hematopoiesis. The hematopoietic cells will leave the bone marrow because it is fibrosed and not suitable for hematopoiesis, and they will reside in spleen and liver, and there they will produce hematopoiesis. The JAK2 mutation occurs in around 50% of cases, and there's also a tendency for transformation into acute myeloid leukemia. The clinical features include the following: fatigue, weight loss, night sweating, and itching. The patients with myelofibrosis, they suffer more if we compare them to patients with polycythemia vera. The spleen will start to increase in size and may reach a huge size. There is anemia due to bone marrow failure and also hypersplenism. Patients with a huge splenomegaly, they may develop portal hypertension. Also, these patients may have splenic infarctions and hypersplenism. These patients may develop attacks of malignant because of peptic ulcer disease. They have sometimes changes in the joints because of hypertrophic osteoarthropathy. They have also bone pain and musculoskeletal pain, and they have also thrombotic episodes and the bleeding episodes because the platelets are dysfunctional. This slide summarizes the clinical features of myelofibrosis, the three important clinical features are anemia, symptomatic splenomegaly, and constitutional symptoms. Now we come to a case. A 60-year-old man is recently diagnosed with myelofibrosis. One of the following lab results is expected. A, low serum iron. B, many target cells in blood film. C, spherocytosis. And D, teardrop cells in the blood film. Also, you will find the answer in the lecture. The laboratory investigations in myelofibrosis will show anemia. The white blood cell count may be increased or normal or decreased. And the platelet count initially is increased, but later on with advancement of bone marrow failure, the platelet count will be decreased. The blood film is important because it will show teardrop cells with leukoerythroblastic blood picture. What is meant by leukoerythroblastic blood picture is the appearance of a mutated RBC and myelocyte or metamyelocyte in the peripheral blood. The bone marrow biopsy is very important for the diagnosis. It will show megakaryocytic proliferation plus fibrosis in the bone marrow. Usually, the serum uric acid and serum LDH are increased. Usually, the patients have splenomegaly, especially during the progression of the disease, and 50% of patients, they will have a JAK2 mutation. This blood film shows clearly what is meant by teardrop cells. When we see them, we should think of myelofibrosis. And this section of bone marrow biopsy shows heavy fibrosis and also new bone formation. The treatment of myelofibrosis, the disease is not curable. We depend on correction of anemia, either by blood transfusion or sometimes we use danazol, one type of androgens, or we may use also thalidomide, which is an immune modulatory agent. We need to prevent the thrombotic events by giving a low dose aspirin. Allopurinol is used to decrease the serum uric acid. To control the activity of the disease, hydroxyurea is the preferred agent, but still we can use alpha interferon to control the systemic symptoms and the size of the spleen. Thrombocytosis also can be controlled by hydroxyurea or alpha interferon. JAK2 inhibitors can be used in patients who have resistant splenomegaly. The only curative treatment for patients with myelofibrosis is the allogeneic bone marrow transplantation. But this procedure carries a lot of morbidity and important mortality rate, especially in these patients, and it is not suitable for elderly patients. Now we come to a question. What do you consider essential thrombocythemia? A highly malignant disease, B, a disease of children, C, a reactive disease, D, a clonal disease. Also, you will find the answer during the lecture. Essential thrombocythemia is the second most common myeloproliferative neoplasm. The median age of diagnosis is 60 years, but in our country, many patients are young. Women outnumber men in this condition, and the morbidity and mortality from ET is predominantly related to thromboembolic attacks and less commonly due to hemorrhagic complications. 40% of patients will have JAK2 mutation or MPL mutation. The clinical features are either vasomotor, like vascular headaches, visual disturbances, erythromelalgia, paresthesia, and cutaneous ulcers. And some patients with repeated cerebral ischemia, they may develop cognitive or psychiatric deficits. The thrombotic complications include arterial occlusion resulting in cerebrovascular accidents, coronary ischemia, ophthalmic problems, and ischemia of digits and toes. The venous thrombotic complications may affect the lower limbs or unusual sites like portal veins and mesenteric veins. Hemorrhagic manifestations include bleeding from the GIT or from the mucous membranes, and obstetric manifestations may include first trimester spontaneous abortion. Some of the patients may develop splenomegaly, but rarely it reaches a large size, and transformation into acute myeloid leukemia is a rare event. The laboratory investigations will show in the blood picture, there is persistent thrombocytosis, and the platelets are of large size, and sometimes the white blood cell count may increase. This is important, the persistent thrombocytosis, because some patients may have transient reactive thrombocytosis after surgery, after an episode of hemorrhage, and in patients with iron deficiency, and after splenectomy. The JAK2 mutation or MPL mutation are detectable, as I said, in 40% of patients. Bone marrow study will show clusters of large megakaryocytes. And it is important in this condition that we should exclude iron deficiency anemia, chronic myeloid leukemia, which can sometimes be manifested initially as a thrombocytosis, and also myelofibrosis, because some cases of early myelofibrosis may present just like essential thrombocythemia. This blood film shows large size platelets that is seen in patients with essential thrombocythemia. The risk stratification for essential thrombocythemia is important because it will decide what line of treatment that we choose. The low-risk patients should have all of the following. Their age should be less than 6 years of age. They have no history of thromboembolism, and they have no cardiovascular risk factors like smoking and hypercholesterolemia. The indeterminate risk group, they are not included in the low risk group or the high risk group. The high risk group, they should have one or both of the following: an age more than 6 years, and or a history of thromboembolism. Now we come to this question. A 40-year-old man who has no cardiovascular risk developed essential thrombocythemia. His MPL mutation test is positive. The best treatment option is A, observation, B, aspirin, C, hydroxyurea, and D, alpha interferon. Also, you will find the answer later on. The treatment depends on the risk category of the patient. For low-risk patients and intermediate risk patients, they should receive low-dose aspirin, while high-risk patients, they should receive low-dose aspirin, and we should decrease the platelet count, mainly by hydroxyurea, but in pregnancy, we prefer to use alpha interferon. So in conclusion for this lecture, one, myeloproliferative neoplasms are chronic disorders arising from bone marrow stem cells. The hallmark is JAK2 mutation and variable tendency for acute myeloid leukemia transformation. Two, polycythemia vera presents with erythrocytosis, splenomegaly, and thrombotic tendency. Control is by phlebotomy, aspirin, and hydroxyurea. Three, primary myelofibrosis presents with anemia and huge splenomegaly. It is treated with a blood transfusion and hydroxyurea. Four, essential thrombocythemia presents with thrombotic tendency, and in high-risk patients, it is treated with aspirin and hydroxyurea. Thank you for listening, and I hope that you enjoyed this lecture.